I'm going to turn on the recording and we'll get started with stuff. Give me just 1 second. All right, it is your last chance. If you're one of the 2 people that haven't submitted your case studies, you need to do it right now, or you will be losing points on your exam. And we're going to start off by going through the case studies real quick. So the first one we're going to look at is the 21-year-old with elevated ICP. So he was in a closed head injury from a motorcycle accident. This is pretty common. A lot of times people on motorcycles are unhelmeted. You'll figure out when you work in the trauma center that there's a reason they have such poor outcomes. But so closed head injury, history of multiple fractures. Generally, people with high-risk behavior have had high-risk behavior for a while. It's not a new thing for him. So he's had to go to the operating room several times in the past for reduction of these fractures. So when you start hearing that, things that come to mind, he's been under anesthesia before. He hasn't had trouble with that. No medications daily. As far as vices, he does everything, smokes, drinks, and does IV drugs. So when you hear that, start thinking about he may not respond quite as well as you would hope to any sort of medication to bring his blood pressure up. He may have an increased MAC requirement as well. And then you also want to see if he's acutely intoxicated as part of his motorcycle accident, and that's how he wound up in this situation. Family history, no anesthetic problems. So again, that kind of reinforces not having to worry about any sort of anesthetic problems because of MAH or anything like that. So that's always kind of nice to hear. When you start looking at abbreviated questions you ask these people, big ones are allergies and history of anesthesia problems. So if you have a limited amount of time to get information from them, or somebody like this that's maybe not real cooperative, either because they're intoxicated or because of their head injury, those are kind of important ones to hit. Another one you always try and throw out there, even though in the setting of trauma it's usually disregarded, is the last time they had anything to eat. So looking at his airway, he's got some micronathia. He's also got a pretty big overbite and poor mouth opening. So from an airway standpoint, he sounds like he may not be real easy to intubate. So I would probably make sure I had some sort of video device available as well. Maybe not as your primary airway, but just to make sure you're on the safe side. From a neuro standpoint, he's got some decreased sensation and strength on the left side and a whole bunch of scars. C-spine has been cleared by x-ray. One thing you have to keep in mind when you start looking at cervical spines, just because it's been cleared by imaging doesn't mean it's been cleared clinically. So if you have somebody that's acutely intoxicated, you really can't clear their C-spine because they could have some sort of distracting stuff. Same thing with this guy. He's got a head injury. So it may be a little bit harder to kind of clear his C-spine because he may be distracted by the fact that he's intoxicated and he's got this big old subdural. MPO status, of course, he ate everything he could before he wrecked his motorcycle. So that's something you need to kind of reinforce as far as doing an RSI. So as far as the case itself, things for you to think about for this patient. We've talked about his full stomach, so he's probably going to be an RSI. We talked about the potential for it being a difficult intubation, just because of his overbite, his limited mouth opening. He may still be in a cervical collar because his C-spine hasn't been cleared clinically, so that's something else for you to think about with this patient. And then finally, the kind of overriding theme is this elevated ICP because of his head bleed. So when we're doing our induction, we want to make sure that we maintain perfusion adequately. So things that will kill people with head injuries, the big ones are hypoxia and hypotension. So we want to make sure during induction that we keep him well oxygenated, and we also make sure that we keep him well perfused. So things for you to think about in that patient: what is driving his blood pressure? Potentially he has other injuries that haven't been identified yet. So you may have to bring his blood pressure up a little bit higher before induction, just so if you have any sort of dip that he maintains adequate cerebral perfusion. So with his full stomach, he's going to be an RSI. So from a medication standpoint, induction-wise, propofol may not be your best choice just because it does tend to cause hypotension. So I would probably skip over propofol and either use ketamine or etomidate in this patient population. Some places they'll use Versed. Again, you tend to see hypotension in these patients. So I would probably skip over that and use etomidate or ketamine. As far as a paralytic, I would use either full dose rocuronium or sucks. Just make sure if you are going to use sucks that you go ahead and provide some sort of precurization so they don't fasciculate. Sucks will also increase your intracranial pressure. So a couple questions popping up. Would you anticipate a higher ICP? Yeah, so if you think about the Monroe-Kelly doctrine, think about your skull as a box. And inside that box, you've got three components. You've got tissue, you've got blood, and CSF. So you've got an increased amount of blood because of the subdural hematoma. So as a result of that, you're going to see your intracranial pressure go up. As part of that, you've got to do something to decrease that pressure. So we'll talk about that in a minute. But yes, I would anticipate with any sort of elevated intracranial pressure or any sort of space occupying lesion that your ICP is going to be elevated. The next question is, won't ketamine increase intracranial pressure? Yes, ketamine will increase your intracranial pressure, but it's not as clinically significant as we used to think it was. Generally, you see less than a 5 to 10 point increase. And the other thing is, look at the big picture. Even though you see an increase in ICP, you also have an increase in your CPP because it drives your blood pressure up. The transient increase in ICP of like 5 to 10 is not quite as important as maintaining the perfusion. So if you have somebody that is literally just running on their sympathetic drive and you give them like propofol or etomidate or something that drops their blood pressure, you see a more significant decrease in the CPP because of that blood pressure component. So ketamine's not quite as bad as we used to think it was. With that being said, one of the other things you'll see is a lot of times in trauma settings or the same patient population that's really just running on their sympathetic surge, you may see that a half dose of induction ketamine is given, so usually like 0.5 milligrams per kilogram versus the traditional 1 to 2 milligrams per kilogram. So, and that's still somewhat controversial, but that seems to be the direction the literature is heading. As far as what would I anticipate as ICP being, if this is somebody that's being taken to the operating room emergently, I would anticipate his ICP is probably going to be 30 or 40. The downside of that is usually you're not going to be able to measure it because he's got no sort of monitoring device in. Depending on what happens intraoperatively, they may leave a ventric in place or they may put a bolt in to monitor him post-procedure. It would just depend on the extent of the lesion and whether or not they decided to leave a flap off or something like that. So if you guys think of questions as we're moving through it, just throw them out there. It's no problem at all. All right, so for induction, we talked about our sedatives, we talked about our paralytics. I would also consider a significant dose of fentanyl or lidocaine for this patient because, again, during that laryngoscopy, that's when you tend to see the biggest increase in ICP just from the direct stimulation. Now, the caveat to that is you can always give more medications, but you can't take them back. So if you have somebody that you're potentially worried about their blood pressure being all over the place, or maybe he's got other traumatic injuries that you haven't found yet, I would probably hold off on the fentanyl just because you tend to experience hypotension in the setting of trauma with opioids. So I would probably give a full dose of lidocaine and hold off on the fentanyl for now. During your induction, you can work it in slowly if needed. But what you'll see is if you go ahead and give that patient fentanyl, a lot of times you hate your life for like the next 30 minutes to an hour because you're chasing your blood pressure. And it's usually because of that. It's not overall because of the traumatic injuries. Those contribute to it, but it's not the same as a normal healthy person. So we've got lidocaine, fentanyl, we've got a sedative, and we've got our paralytic. Depending on what medication you use for induction post intubation, you may need a long-term paralytic. Again, I would go to rocuronium or vecuronium for that. So let's talk a little bit about the dosages as far as what you want to see for your sedative agents. That's one of the things we're going to go over today anyways, but we'll just start off with it now. So I mentioned ketamine. For this patient population, I would probably go down to 0.5 milligrams per kilogram. With the propofol or etomidate, I would probably also decrease my dosage. So if I was going to use propofol, I would probably consider doing 1 to 1.5 milligrams. And if I was going to do etomidate, the normal dosage is 0.3 milligrams per kilogram. You may consider decreasing that as well to down to 0.2. And this is one of the hardest things for you guys to kind of grasp as you start looking at pharmacology, because there's no hard and fast rules. A lot of times it's evaluating each patient and all the factors, trying to figure out what would work out best for them. So start thinking about those considerations when you look at patients. So that's what I would probably do from an induction standpoint. If you were to use midazolam, usually doses like 0.1 milligrams per kilogram. The nice thing is if you're using vecuronium, your midazolam dose and your vecuronium dose would be the same. So like if it worked out to be a 100-kilo patient, I would give 10 milligrams of Versed and then give 10 milligrams of vecuronium as well. So that's an easy way for you to remember that. If you happen to come across pancuronium, the dosage is the same as Vec. It's that 0.1 milligrams per kilogram. It's not commonly used, but you never know when we're going to have some sort of weird drug shortage or something like that and have to use something that you don't commonly use. Some places, people still like it and use it pretty routinely. I used to use it a lot for longer orthopedic cases because I could get away with just dosing one time as opposed to having to go back and dose and dose and dose again. So we've talked about the potential for difficult intubation. So evaluate the patient. We've looked at his airway. We're seeing some indicators that he may be problematic. As I said, I would make sure I had a video scope available. I encourage you guys to start off DLing these patients and then move on to video scopes, because you never know when your scope's not going to work, it's not going to be available, and you really have to have that experience to fall back on to make sure you're able to get that airway secured. All right, so the other thing that we haven't really addressed is this elevated intracranial pressure. So what can we do to help reduce that ICP? So if you think the patient's herniating, indicated by like blown pupils, severe hemodynamic changes, like you think they're starting to herniate, think about hypertension, bradycardia, all those sorts of things that you tend to associate with Cushing's triad. Hyperventilation is a good start. Now, the nice thing for us is that we're able to see what his end-tidal CO2 is. So usually we're going to kind of do a controlled hyperventilation down to like a CO2 of 30. Other things, you want to try and make sure that you keep the patient hemodynamically stable. As I said, hypotension tends to be worse than hypertension. So make sure you support their blood pressure. If you think that they've got other trauma, you may consider getting some blood products into the patient early. The other thing you'll see is the biggest area outside of intubation for hemodynamic changes is when they actually get into the skull and start relieving that pressure. And it seems kind of strange because it's not a whole lot of blood loss, but you can actually bleed to death from skull injuries as well. So you may see that when they start opening up that skull, there's a pretty significant amount of blood loss. It's kind of hard to quantitate sometimes because some of that blood, is already there and it may just be hematoma. But at the same time, there was obviously some sort of blood vessel injury that caused this. So you may have acute bleeding as well. Other things outside of hyperventilation, you can consider using 3% saline, mannitol. For 3% saline, the dosage kind of varies from one place to another. Some place they'll do 20 to 150 mLs. Some places they'll go on and do 22% saline. If you do that, it's usually not going to be any more than 10 to 20 mLs. The other thing you'll see is a lot of times that's continued as an infusion. For your mannitol, usually it's going to be a half to 1 gram per kilogram. And if you're using it in the setting of elevated ICP, you really want to get it into the patient fast because you're trying to get that pressure down quickly. So I know in the ICU, we were like really good at doing slow infusions. This is something you want to get into the patient pretty quickly to try and get that ICP down. Other things, trying to avoid any sort of hemodynamic swings. So like we talked about for your laryngoscopy, consider some lidocaine or fentanyl to try and blunt them so you don't have tachycardia and hypertension. You want to be very careful with how much agent you're giving them. You'll see a lot of times in these cases, we cause our own problems. So we're not paying attention to the patient and all of a sudden you've been running the gas heavy because the pressure was going up, and now you've dropped their pressure. So just be very cautious and kind of let things smooth out a little bit before you make real acute changes. Other things to think about in these patients, avoid using nitrous oxide because you do have the potential to increase the ICP. Very cautious with fluid administration in these patients. I think that was one of the questions that popped up. Remember, fluid that's going into this patient is only going to stay intravascular for a limited amount of time. So crystalloids, we generally say about 30 minutes. So after that 30 minutes, all of a sudden you're going to see that you've started causing edema. So when we give that mannitol, we're trying to pull that fluid out. Remember those three components inside the box? So you're trying to get the fluid out of the brain to reduce the overall size. So you kind of kick yourself in the foot if you start giving fluid at the same time as trying to give mannitol, because you're pulling fluid out and at the same time you're putting fluid in. So in these patients, a lot of times we'll preferably go to either colloids like blood or albumin, or we'll use pressors, because you're trying not to put all that extra tissue into these patients. Ray asked about fluid for these patients. A lot of times we're still going to use something balanced for this. We generally don't use saline for much of anything. With that being said, you may go someplace which is a little more dated, and you'll see that they still use saline for lots of stuff. The balanced fluids are generally a little bit better for these patients than using saline, or certainly something with dextrose like D5W. All right, so moving on with that one, we talked about how to address this ICP. During the case, again, you want to maintain hemodynamics. You may see that they do put in some sort of ICP monitoring or drainage device. The two most common ones we see are a fiber optic bolt, which is just a little fiber that sits on the end of a bolt that's placed under the skull but above the dura. So that allows you to monitor the intracranial pressure but not address it. The other thing we see a lot of times is a ventriculostomy placed, which allows you to not only monitor the ICP but also to treat it by doing a drainage. So thinking back to those components, doing that drainage allows you to take out any free fluid or blood. Usually it's going to be CSF, but if you do have some sort of communication, you could be taking blood out as well. So that'll allow you to reduce the overall intracranial pressure. As far as monitoring devices and other things for these patients, pretty much any sort of crani arterial line is essential, because you really need that beat-to-beat monitoring for the patient. You don't necessarily need a central line. Some places they like to have central lines for all their cranies, but you have to look at them as kind of two different categories. So you have like your scheduled cranies, like, somebody's got a tumor, we're bringing them in. And then you have your emergent cranies where they're really having brain damage the longer that pressure stays elevated. So you don't want to have anesthesia be the reason that they couldn't get into the skull quickly. Other places, they just use peripheral IVs across the board for their cranies. Both of those are perfectly acceptable. The only advantage as far as having central access is if you were to have some sort of venous area embolism, it does allow you to aspirate that air. And then, of course, you've got easier access to medications. Things for you to think about for these patients. If you do traditionally, as far as like from an anesthesia standpoint, almost all of the central lines we put in are going to be like right IJ. If you've got somebody that's got elevated pressure inside their head and you put a line into the jugular vein, it's going to not so much, but slightly affect the venous drainage. So you may consider doing a subclavian or femoral line for these patients. The nice thing, if you want to go ahead and get the case started, you can get down to their groin and put a femoral line in while they're already working on the skull, if you have enough hands available. But it really just depends on kind of your setup. If I were a solo provider, I would just go with peripheral IVs. And if I need to put a central line in at the end of the case, I'll do that. But I'm not going to hold up the case to try and get access outside of those peripheral IVs. On the other hand, if you're having trouble getting access, have a pretty low threshold to just go to a central line. Most of these patients usually come from the ER or the ICU with adequate access, though, so that's not a huge problem. Tyler asked if you would need a central line if you were anticipating high percentage saline. I wouldn't worry so much about it for the 3%, but if you've got somebody that's going to be on 22%, you may need it. The other thing is, depending on what's going on with their volume status and kind of the practice of that facility, you may see that they want a central line to monitor CVPs as well for that fluid status. But we're seeing more and more often that places are using non-invasive monitoring for that as opposed to the CVP, because we know it's not a real great monitor. During the case, as I said, kind of maintain adequate hemodynamics. You'll see that a lot of times these patients go back to the ICU intubated and stay that way for the first 12 to 24 hours. That way they can kind of get their ICP settled out. The other thing on this patient specifically, he's acutely intoxicated. Taking him to the operating room did not make him sober. So the last thing you want is him acting the fool when he wakes up. So a lot of times we'll let them go ahead and metabolize that alcohol over the next day or so and then extubate him. And I would anticipate with this guy with this history of substance abuse that he's probably going to be a little bit more challenging. Sometimes these patients are beneficial to run on a dexmedetomidine for a little while as you wake them up. It just makes it a little bit calmer. Because even if you go in and do a craniectomy or a craniotomy, you're still going to have the potential for that elevated pressure to increase. And when it happens, you may wind up with a rebleed. So especially during extubation, you want to try and keep them calm. And that carries over for tumors as well. We try and have kind of smooth emergence for those patients. A lot of places prefer isoflurane for their neuro cases, but over time that's kind of fallen by the wayside and people are using SIBO for pretty much everything. Any other questions about this case specifically?
Right. Hey, Doc Cornelius.
Yeah.
It's Richard here. I was thinking, I guess I was all wrong. I was thinking from pharmacology, propofol decreasing CMRO2 and cerebral blood flow would be ideal for us to use in the patient. So I kind of went using propofol for my patient. Is it not? It's better to use ketamine instead of propofol, or
I would use ketamine or etomidate because the things that really kill these patients are, like I said, are hypotension and hypoxia.
Okay.
And you're going to have pretty profound hypotension in this patient, especially if it's somebody that's already gotten mannitol, you're doing fluid restriction. They're not going to do really well with causing that vasodilation with the propofol. So I would do something that tries to keep them a little bit more cardio stable, like etomidate or ketamine.
And then since they're acutely intoxicated, you wanted to go lower with the etomidate and the ketamine and lower dose?
You may, and you may also be able to do that just to try and reduce the hemodynamic changes. Because like I said, if you've got somebody that's just running on that sympathetic drive, when you give them a sedative, you're going to knock that out and their pressure is going to crump. I'm sure you guys have seen this before in the ICU or the ER where somebody, has been struggling to breathe for hours and hours and hours, and maybe their pressure was even a little bit high, and then they get intubated, and then you've got to deal with hypotension afterwards. So part of that comes from knocking out the sympathetic drive, and then the other part of it's the positive pressure ventilation. So it can kind of be a bad combination for you, especially in this patient that you want to keep their blood pressure stable or elevated.
Awesome. Thanks, Doc.
Yeah. Any other questions about that patient? So Jason asked about people mixing ketamine and propofol for a more balanced anesthetic. This may be a case where that's beneficial. I do it a lot of times for not necessarily like induction, but for longer periods of time. So like if I'm doing a TIVA, I'll usually add ketamine to my propofol. The other thing you'll see is that you may do it for kind of a more balanced approach to your blood pressure. The downside in this patient population is if you mix the two of them together, sometimes it's kind of hard to regulate what's going on with your blood pressure. So usually, even if I'm going to give both medications, I won't actually mix them other than if I'm doing it as an infusion. So I may give them a half dose of ketamine and a half dose of propofol. But like I said, in this patient population, I'm probably just going to use one agent to make my life a little bit easier and have better control over what's going on. But that is, I won't say a common practice, but it happens pretty regularly. People may even refer to it as ketofol, just because it's a combination of the two medications. All right. The next case is a pretty straightforward pediatric case. It's a 4-year-old coming in for tonsils and adenoids. I wanted you guys to start kind of thinking about pediatric stuff. because you're going to see this when you get to clinicals if you're at a facility with pediatric patients. And this is a pretty basic pediatric case. You'll see the vast majority of kids that you take care of are going to be for tonsils, adenoids, and myringotomy tubes. Depending on where you go, you may do, if you're in like the ENT room that day, you may do 5 to 20 of these. So they're pretty quick turnovers as far as cases go. For the patient, it's an obese 4-year-old. So he's got sleep apnea. Sleep apnea may be because he's fat, or it may be because he's got kissing tonsils. But you'll see a lot of times these kids come in, even if they're not obese, with kind of complaints of snoring, sore throat. The long pauses is probably going to be associated with the sleep apnea itself and his obesity. It's probably not going to be the tonsils. As a result of not sleeping well during the day, he doesn't stay awake very well during, or not sleeping well at night, he doesn't stay awake very well during the day. The other thing you'll see a lot of times in this patient population is they tend to have like recurrent URIs. So you'll see that they come in, especially if it's towards the winter, with like snotty noses. They may have a little bit of a cough. And we kind of go back and forth about whether or not these are okay patients to take to the operating room, or if we should hold off on taking them. And the problem you run into is these kids never have really a healthy period until they get their tonsils and adenoids out. So you want to make sure that they don't have any sort of acute infection, and then usually proceed with it. The other part of that is because they do have all these snotties and crusties and stuff, you anticipate that they've got a higher propensity for laryngospasm or bronchospasm. And especially when you've got somebody like this that's already obese, it can be problematic for you. So otherwise, he's not had any surgeries before, and you'll see a lot of times that these kids coming in for tonsils and adenoids have not had surgery before. So you may not have the availability of their previous anesthetics to figure out if they have any sort of family concerns over MH. So a lot of times it's going to be turning and asking mom and dad, do you have any trouble with surgeries, nausea, vomiting, fevers, those sorts of things. And they may not have had surgery, may have to go a little bit higher up the family tree to figure out what's going on there. So looking at the kid, he was a little bit big. Otherwise, vital signs are pretty normal. His heart rate's a little bit high, but that's normal for a kid. Respiratory rate's a little bit elevated. Same thing, it's pretty normal for a kid. Looking at his airway, you really can't visualize his pharynx because he's got this big, large tongue. Remember, kids kind of have weird airways. It's not uncommon to have tongues that are a little bit larger. NPO status, he's nice and NPO. These are generally pretty quick cases. So, the surgeon's comment, the procedure is going to take 30 minutes. This may be one of those times where he's actually right. And depending on how good your surgeon is, it may even be less than that. I've seen surgeons that knock out tonsils and adenoids in 5-10 minutes. So plan on pretty quick turnovers. And that's something that comes into play when you start thinking about your medications. You don't want to give a whole lot of long-lasting stuff. Other things for you to think about for this patient, as far as your medications up front, is the kid calm? Is this somebody you need to give like oral Versed or some sort of transnasal medication like Precedex or midazolam to help them relax? Sometimes you'll see that trying to get that medication into the kid may cause you more problems than it's worth. The nasal stuff burns a little bit. Nobody likes having stuff shot up their nose. The oral stuff, depending on how you mix it, may taste funny. And some kids just aren't real good about doing anything. Other kids, you'll give it to them and they just suck it down and you're good to go. But you may see that you actually get this kid more worked up by trying to give them something than just going without it. You'll see for kids, generally the way they go to sleep is the way they wake up. So if they're, throwing a fit going to sleep, you may have problems on the back end. Something that's really helped out as far as kind of smoothing the emergence for kids is Precedex. It works out pretty well for most of these patients. The problem you run into with this specific patient is with his sleep apnea, even with his tonsils and adenoids being removed, he may still have a higher likelihood of obstructing. So if they're extra sleepy, it can be problematic for you. So generally the way this is going to work on pediatric patients, you'll bring them into the room. You will start oxygenating them. I usually take the mask out to holding with me. and just let them play with it. That way it's not kind of a strange thing to them. You can tell them it's a pilot mask, whatever you want to do. They think they're an astronaut flying around with a face mask on. That's great. That way they're comfortable with it. When I take them into the operating room, if it's something they're already okay with, I just hook up the circuit to them and let them start breathing the oxygen. Let them breathe that in, get them as pre-oxygenated as you can. Then you're going to transition over to nitrous. So usually the way it works, we always called it flight 738. So you'll have 7 liters of nitrous, 3 liters of oxygen, and then when you finally get to the point where you turn the sevoflurane on, you're going to kind of gradually go up on it, and you're eventually going to hit about 8% sevoflurane. So they're pre-oxygenating. They start breathing in the nitrous. The nitrous doesn't really have a bad smell to it, so they generally do okay with that. And then you use that to start getting them sleepy. At some point in there with the nitrous running, they're going to start having some respiratory depression, and you're just going to transition into taking over their ventilations for them. And then finally, at that point, since they're already kind of sleepy, you can go ahead and start turning the ISO up. Usually I increase it by like 2% at a time and let the patient kind of drive how you increase it. With that being said, depending on the kid, some of them just don't cooperate no matter what you do. And you may wind up having to do a little bit more urgent mask induction. So if you come in, you start pre-oxygenating, or they're just fighting, screaming, throwing a fit from the start, you may forego the nitrous and just move straight to SIVO. They're already upset, so you're not really losing anything. And with that, you'll just go ahead and turn your SIVO up all the way to 8%. The nice thing is if they're upset, they're breathing faster. So you tend to get the gas into their system faster and they go out faster. The downside is, we like kids. We don't want like this traumatic experience for them. But usually they don't remember things that happened before the age of 3 or 4 or so anyway. So it's not such a big deal. It's more important for mom and dad to not have some sort of traumatic memory of little Johnny like crying all the way to the operating room. Other places you go, parents may come back or walk back to the operating room with their kids. With COVID, a lot of that went by the wayside, but we're starting to see it come back again. As far as intubation, again, there's a potential with his obesity and his large tongue that he may be a little bit difficult to intubate. My experience has been generally, as long as the kids don't have some sort of syndrome, they're usually easy intubations. I would consider bringing like the glide scope or one of the fiber optic scopes into the room to have as a standby, but a lot of times you're not going to have trouble intubating these kids. So kid goes to sleep. Now we're going to go ahead and get IV access in him. So one person's going to mask the patient with the SIVO going, and then somebody else is going to go start the IV. While you're in residency, a lot of times what will happen is the CRNA is going to take over ventilating the patient, and you'll go start the IV. There are also some places where the OR nurse will be the one to start the IV for you because you're up there masking the patient. Don't miss out on any of these pediatric IVs you can. They tend to be a little bit more challenging than adults, depending on how chubby the little guy is. So something for you to think about there. So IV goes in. You may or may not administer a paralytic. Some places they paralyze all their kids. Other places they don't paralyze any of them. So you've got the kid masked down. You can intubate a patient with just the sevoflurane and nitrous, but they'll usually go ahead and give some propofol as well. And for kids, it's a full strength dose of propofol because they metabolize it so quickly. Other things to consider post intubation: steroids and Zofran are pretty common. So usually what I'll do as far as the dosage for those, and there is some variability from one place to the next. And for kids especially, I would recommend getting a pediatric app. Most of them, you just put the kid's weight in there and it'll give you dosages. But I usually do 0.2 milligrams for my Decadron and 0.2 milligrams for my Zofran per kilograms. Sorry, not 0.2 overall. So kids comfortable. These aren't horribly painful procedures as long as they don't get dry. A lot of times when we give the kid the Versed up front, we'll also give them PO Tylenol. Some places, if it's not a kid that's able to take medication by mouth, they may just do rectal Tylenol after induction, and that helps out a lot. They may get little doses of fentanyl, or they may not. Again, it really just depends on the clinical practice that you're in. All right, so big things to think about. We talked about the potential for airway obstruction in kids with sleep apnea. With his obesity and kind of his sleep apnea, he may be problematic to wake up. So you may want to hold off on giving this kid Precedex just because he's going to be a little bit sleepier on the back end. One thing you can do, depending on how it works out, sometimes we will give PO pre-meds, and then at the end of the case, we'll put down an OG tube or even just a 14 French suction catheter and suck out anything that's left in their stomach. So that way, if it's not something that they've already absorbed, you may be able to get the rest of it out. And that tends to help out with like respiratory depression. On the other hand, like if you gave PO Tylenol, you don't want to suck that out because that's their pain relief you just got rid of. You may need to use an oral airway for the kid. You'll see that when you get to the operating room, have a pretty low threshold for going to oral airways. As your skills get a little bit better and better, you don't need it quite as often. But you may consider if you get up there and you give like 2 or 3 breaths and you're just having a hard time, you've already tried repositioning the airway, I would consider going to an oral airway pretty quickly rather than sitting there and struggling, because it just makes your life a little bit easier. You're already going to be kind of stressed out about what's going on here. So I would consider putting an oral airway in pretty quickly for those patients. All right. So it's a pretty straightforward PEDS case. You should be able to get them extubated, get them over to recovery, and be good to go from that standpoint. All right, let's see what questions we have. Blood pressure, at least the blood pressure as I was seeing, Matt, were like 70s and 80s. I'm okay with that in a pediatric patient. Usually kind of my low threshold is like 70. So, at that point, if his pressure goes a little bit lower, I'm not terribly worried about it, other than if you've got some sort of other things going on. So the kid's got, some sort of cardiac issues. This is not like a straightforward pediatric case, something like that. Maybe we're doing a cranny. Those patients, I would be a little bit more inclined to address the blood pressure, but I'm okay with 70/40, especially if I know that I caused it. You'll see a lot of times with the high sevoflurane with induction, you tend to have an elevated heart rate and your blood pressure goes soft on you for a little bit. You can always just give them a little bit of fluid and then get them back over. Kids generally struggle a little bit more with that fasting period than adults do. Sometimes you'll even see that, kids just sneak stuff in the operating room in the morning and, you wind up having to delay or cancel cases because they're not really MPO. But 70/40 in a 4-year-old, I'm not too worried about. All right. Any other questions on that case? Okay. So for everybody that did that, that will be 2 points on your exam. There will be 2 more points for the other 2 case studies. Please complete those. And then we're going to move on to the lecture itself. So we're going to kind of burn through this medication lecture. Some of this will be stuff we've already talked about. We're going to do about half of it today, and then we'll do about half on Thursday. The other thing we're going to do is just kind of go through that reference guide. We've tried to make it as easy as possible for you guys to have something that you can use as kind of a standard. Like when I was talking about those cases, you'll see that there's just times where there's variations. Whether it's a local practice or because it's something patient specific that you wind up changing your dosage outside of what we've given you. So just keep in mind, this is a jumping off point for these medications. You may see that there's changes for any reason, but this is a nice reference for you guys to have. All right. So just kind of an overview. Why is this so important? We're going to try and go over as many medications as we can, but we're really just going to hit the common ones. There's so many medications that you have to worry about in addressing anesthesia that's why you go to school for 3 years, to try and figure it out. I'm going to try and put a lot of information in here, but we're not going to go into depth on stuff. So if you have any questions, please feel free to ask me offline, catch me after class, any of those sorts of things. And again, this is not a complete list of all the medications. It's just an attempt to kind of highlight the common ones that you use. You're more than welcome to go back and look at this lecture. And if you have any questions, feel free to ask. So one of the first things that's going to happen when you get to clinicals is people are going to start to ask you questions. Indeed, on your first day at your clinical site, you may sit down and take a written pharm test. Part of the reason we have this portion of the class is to make sure you're prepared for that. With that being said, don't consider this everything. You know, it's going to be a couple months till you get to clinicals. Please don't forget all this information between now and then, because indeed, when you get to clinicals, day one, they're going to have you sit down and write down the MAC values of all your gases, the oil coefficients, your vapor pressures, those sorts of things. And it's really just to make sure you're prepared for stuff. But at the same time, you kind of have to understand how those medications are going to affect your patients. And if you can't remember simple things like the dosage, it's going to be really hard for you to adapt when you start looking at, you know, this patient has this issue. You know, this patient has a past medical history of X, Y, and Z. I need to adjust my anesthetic for a different manner. So, like I said, one of the big ones you're going to start off with is going to be your inhalation agents. So, things for you to think about. They are not really any sort of significant analgesic, with the exception of nitrous oxide. So sometimes if you're trying to provide somebody with pain relief, but maybe you don't want to give them an opioid. So think about a patient that's having surgery. Surgery is painful, but you don't want to give them a lot of opioids because maybe they're like that little kid we were just talking about and they've got sleep apnea, they've got obesity. You can use nitrous oxide during the case and then get rid of it. So it's not like an opioid that you can't take back. So nitrous can provide you with that benefit. It's the only inhaled anesthetic that really provides any sort of significant analgesic. But what the volatile agents do is they provide amnesia and immobility. With that being said, they may not be nearly as profound as the straight amnestic agent or a skeletal muscle relaxant. So you get a little bit of sedation, you get some immobility, and it tends to be dose dependent. So if you're running somebody on maybe a half MAC of gas, you increase the risk of having the patient move or having the patient remember what's going on. On the other hand, if you go to like twice MAC or like a double MAC or a big MAC, whatever you want to call it, they're less likely to move and they're less likely to remember things. So you kind of have to figure out the balance for that patient. We do know that we generally adjust our MACs via age and other factors, like we were talking about the guy being acutely intoxicated earlier. All those sorts of things can affect it. How do they work? We're not entirely sure, but generally we accept that we get the immobility via actions on the spinal cord by inhibiting the enhancing the inhibitory channels, so you get a more profound blockade there. But we're not really sure about a lot of that stuff, which is kind of strange that one of our biggest anesthetics and we don't really know how they work. So you'll hear MAC referred to a couple different things. When we're talking about our volatile anesthetic agents, we're referring to the minimum alveolar concentration. And that's really what about 50% of the patients will not show a motor response to being cut on. So remember, that's only half the patients. So your patient may or may not follow the rules. And that's where you start having to kind of adapt things. You know, you've got a patient on what should be an appropriate MAC, but you figure out that their blood pressure is very low, they're not responding to something. You may need to decrease the amount of agent you're administering. On the other hand, you may see that you have a patient on an appropriate MAC and they're still moving. I've heard of patients sitting up even though they were on a full MAC of gas. So you kind of have to look at the patient. Just use that MAC value as a jumping off point. But if you don't know what the MAC value is, you're not able to respond to it. The other thing you'll see is what we refer to as MAC bar. So generally we have a standard deviation of about 10%. So as we start going up by 10%, we start knocking off more and more with patients. So when you get to MAC bar, which is about 1.3 MAC, 99 to 100% of the patients should be appropriately affected. So if you're trying to figure out what you should do to increase your medications to keep that patient from moving, and you're figuring out that a MAC is not appropriate, the next stop is kind of the MAC bar or to block the autonomic reflexes. So go to like 1.3 MAC. Other things that come into play, this is just for the anesthetic gases. So other stuff you're giving may affect that. Usually it's going to decrease it. So if I give somebody Versed, I give somebody fentanyl, I give them lidocaine, Precedex, all those sorts of things, those are going to decrease your MAC value. So you may figure out that the reason that patient only required a half MAC of gas was because you'd given them fentanyl, you'd given them Precedex, any of those sorts of things. So you'll kind of figure out over time how to come up with a really well-balanced anesthetic. But as I said, you've got to know these jumping off points before you kind of start adjusting things. So most common agents we use are isoflurane, sevoflurane, and desflurane, just kind of overall reference points for you. There's specific times that you may use one versus another. Desflurane is kind of the agent of choice for obese patients, just because it tends to go away very quickly. That's primarily affected by the blood gas coefficient being so low, and then the vapor pressure being so high. Your standard MAC for desflurane is 6.6%, so it's a lot higher percentage than the other medications. Downsides of desflurane, you'll see that they tend to become more hypotensive with rapidly increased dosages. And then you may also see that you don't get quite as much sedation and immobility as you do with isoflurane or SIBO. For isoflurane, general MAC dosage for that is 1.1 to 1.2. Reasons we use isoflurane, biggest one is it's inexpensive. So these agents are very expensive to use, especially desflurane. So you may see that hospitals only have 1 or 2 desflurane vaporizers, and you can only use it for certain cases. So be familiar with kind of whatever the practice guideline is there. You'll see that people will oftentimes like fight over the des vaporizers. So, you think you had everything set up, and, you go in your room and your des vaporizer's gone. Well, if you need it, it might be a big deal. If it's not really that important, you're probably okay using something else. Isoflurane's pretty plentiful. There's not a whole lot of people stealing your isoflurane vaporizers. Other thing you can run with reduced flows at isoflurane. So part of the way you save money with that is not running at the 2 or 3 liters per minute. You're able to decrease your flow rate and not have to worry about the compound C that you do potentially have to worry about with SIBO. The other nice thing with isoflurane, at a lower MAC percentage, you will get a more profound effect. So you'll see more muscle relaxation and more amnesia, even on as little as a half MAC of isoflurane. Whereas sevoflurane and desflurane generally require at least a full MAC to achieve those same effects. Advantages of sevoflurane is kind of the middle ground. So it tends to come on quickly, go off quickly, not as fast as desflurane, but a lot faster than iso. It's not very irritating. So if you're doing a mass conduction on a pediatric patient, you're usually going to use sevoflurane because it doesn't really smell as funny as iso does. Now, you will see that volatile anesthetics still have a very specific smell to them, but it's not quite as irritating to the airways, especially as using something else. So you're usually going to use that for your mass conductions. SIBO is the most common volatile anesthetic you're going to see. When I was in residency, we used SIBO for pretty much everybody, other than one hospital we went to that had lots of money, and they used DES for everybody. I'm sure that's gone by the wayside now, but it was when it first came out, and it was pretty common. Other places you go, they don't have a lot of money, and they're saving it, so you use isoflurane for everybody. So, you kind of have to look at the patient and figure out, based off of that, what's beneficial for the patient, and go from there. This is a nice chart for you to reference because it kind of shows you the different hemodynamic effects of all the medications. I leave halothane in a lot of these references because we're seeing more and more of our residents that are maybe going to Mexico, going to Africa, and doing mission trips or like volunteer medical work. And you may run into halothane there, which seems kind of crazy to us, but that may be the anesthetic gas they have available, and that's the only anesthetic gas. It's not like you can walk into the next room and switch out your vaporizer. So this is kind of a review of what I talked about, but the down and dirty, if you're not going to remember anything else about the anesthetic gases, this is what I would remember. Like I said, DES tends to make people cough. It smells funny. You will see that the heart rate goes up, especially if you have that quick onset, like you start dialing it up. It's almost like with your pediatric patients. You know how I told you I usually increase by like 2% every minute or so? Do the same thing with your DES. You'll see if you blast them with DES, they very quickly become tachycardic and hypotensive. The other thing you'll see with DES is that it needs a special heated vaporizer. So you're going to have to plug the vaporizer in. So if you're out of plugs on your anesthesia machine, you may be in a little bit of trouble. So SIBO, as I mentioned, it's not irritating to the airway. You may see that there's a little bit of emergence delirium in kids, but it could just be the kids themselves. Cost-wise, it's kind of middle of the field. It's less expensive than DES. It's more expensive than ISO. Because it tends to stick around a little bit longer in obese patients, you may use something else. We've seen some stuff that hasn't been really clearly studied in humans because it's kind of a bad thing. There's potential that it causes nephrotoxicity in rats. Compound C has not been studied real well in adults or in humans either. But there's some animal models that indicate that's real. As a result of that, we usually keep our sevoflurane running at least a flow rate of 2 liters per minute. Whereas I mentioned with DES and ISO, you're able to decrease the flow rates. For your ISO, it may be used often, it may not. I use ISO for everything other than kids, just because it gives people a little bit different experience. And you figure out over time that if you're familiar with your medications, you're able to titrate things so it doesn't result in a longer emergence. But if you're not very experienced with it, that's the big thing people worry about, is they're going to hold on to the gas and they're not going to wake up quite as fast as I want them to. You'll see a lot of times in long cases where you're not planning to extubate somebody. So think about like a bag and drag patient from the ICU. You bring them on the vent, they're going back on the vent. There's not a whole lot of reason to avoid using ISO for these patients. It's cost efficient. It's very hemodynamically stable. Whereas, using something like SIBO or DES would be really expensive. And you may wind up struggling just because the patients tend to be a little bit sicker. You have to chase your blood pressure tail. For nitrous, generally it's not used in the operating room by itself. You may see some places like dental practices where they use nitrous just alone. But in the operating room, we primarily use it as an adjunct agent. As I mentioned earlier, you may get nice analgesic relief with it. You can use it in a whole lot of different fashions. Some places they will use nitrous on the back end of the class or back end of the case because they want to start getting some of their volatile agent off. So you may see that you start turning down your SIBO or ISO and start turning on some nitrous, and you can kind of use it as like a bridge device. That way you get the gas that sticks around longer out of their system. So that works out pretty well for you. The biggest thing that you run into is that because of the way it works, if you have some sort of container, think about the bowel, think about the brain, think about the sinuses, you may have the potential to cause expansions. And nitrous has kind of been implicated as causing PONV, but over time this has been disproven. You may still run into people that are like, no, you can't use nitrous because it's going to cause nausea and vomiting. So these are just some overall factors which may either increase or decrease your anesthetic requirements. And again, some of these are kind of falling out of favor, but this is the actual reference. So increased anesthetic requirements, chronic alcoholics, infants, remember your highest MAC is going to be at about 6 months. After that, it starts going downhill. Red hair, hypernatremia, and hyperthermia. Decreased anesthetic requirements are associated with acute intoxication. So they've already sedated themselves before they got there. Elderly patients, low electrolytes, so hyponatremia, low temperature hypothermia. Patients that are anemic, think about very anemic, like you probably shouldn't have taken them to the operating room with the hemoglobin of 5. Patients that are hypercapnic because they've already sedated themselves. Same thing with the hypoxia, and then finally pregnant patients. So why do we use gases? And this is one of the really hard things for students to figure out, especially when they're coming from the ICU. Because in the ICU, you sedate people with infusions. In the operating room, we really don't. They're just going to get this ongoing infusion of volatile gases and sometimes some IV stuff. as far as their sedation. So you'll see that we don't run drips a lot of times other than outside of doing a TIVA. So big advantages for us is quick on, quick off. Whereas if I had somebody on like a propofol infusion, I have to wait on that to be metabolized and go away. I can titrate it very quickly because I can either dial the medication up or dial it down. Whereas if I'm using an IV agent, it takes a lot longer to get in there and it takes longer to be absorbed. Medications are very potent, but they do have a very narrow therapeutic window. Some patients do really well with volatile agents. Some patients you struggle with. The other thing you may see for some of these cases, sometimes like we'll be working on airway tumors and the patient may not stay intubated. So you may be transitioning from using a volatile agent at the start of the case to where they remove your endotracheal tube and you have to go to an IV infusion and go back and forth. So you may see that there's some change there as far as what you have to do for the case. We're able to watch what the patient breathes in and out and kind of use that as a correlation to what they're getting in their brain. Hopping through questions. Yes, Ray, I meant compound A, not compound C. Maybe it is compound Cornelius, I'm not sure. So big things for you to think about for the medications. Make sure you know why you use one medication versus the other. Make sure you know your dosages because it's going to be the big jumping off point for you. If you don't know the jumping off point, you really won't be able to do stuff. As far as the medications, we don't really know how they work. So you can just kind of use general reference points. Big things that kind of come into play for these medications, usually it's going to be provider preference, facility preference. You know, if you don't have DES available, you can't use DES, or the case that's actually going on. So for pediatric patients, you know, usually we're going to use sevoflurane because it's not irritating. DES would be kind of irritating for the patient, so we generally don't use that. All right, so we're going to transition from the volatile agents to the IV induction agents. Propofol is by far the most common agent we use, primarily used for induction. You may use it for sedation cases as well. So like patients that are going in to have a colonoscopy or an EGD done, they may just get propofol. One of the reasons we do that is it's a little bit more pleasing for the patients because it goes away quickly. Some places you'll go and you'll see that they have IV sedation done with like a nurse who may not be able to use a general anesthetic medication like a propofol or ketamine or something like that. Those patients tend to be strung out for the rest of the day, and they're a little bit less pleased with their anesthetic. On the other hand, they've saved money because they haven't had an anesthesia provider there. So there's kind of some variation there. Other things you'll see is sometimes we will use this in lieu of using volatile agents, and the patient will get a TIVA or just a total IV anesthetic. So they're not receiving any sort of volatile agents. Primarily, we do that for things like neuromonitoring, but maybe it's something like your patient has malignant hyperthermia. So you're avoiding the use of any sort of volatile agents for those patients. The other nice thing about propofol is that it is an antiemetic, so you do reduce your risk of nausea and vomiting by administering propofol. Preparation, I've never seen it in any other concentration. It's generally going to be 10 milligrams per cc. Usually it comes in a 20 ml vial, but we also have 100 ml vials, and I have seen 10 ml vials, and 50s for that matter. So just be familiar with whatever's available to you, because you know, you may have to use like a whole bunch of little 20 ml vials when 100 ml vial would have worked. And the cost savings can vary from one place to another. So just be familiar with whatever the practice is and try and plan ahead. A lot of places you have to waste propofol just like you would as a controlled medication. Other places you don't. It's kind of weird. Like in Louisiana, I didn't have to waste propofol, but I had to waste ephedrine because ephedrine was controlled and propofol wasn't. So there's some variation from one place to the next. just make sure you know what it is, because it's a quick way to get yourself in trouble as far as medications, not having your stuff accounted for. Next thing you know, you're doing drug tests and people are talking about you and it goes poorly. So as far as the induction dose, kind of the mid-range for this is 2 milligrams per kilogram. If you're going to use a range, it would be 1.5 to 2.5 milligrams. Again, it's patient dependent. So if you have somebody older or sicker, you may decrease your dosage. For sedation, and this is just sedation, not trying to achieve general anesthesia, 25 to 100 mics per kilo per minute. This is most commonly going to be run on an infusion pump, but you'll see some places that they just kind of do the eyeball mini drip method. Again, just be familiar with what the practice is there, and you may see both of them. So sometimes you may not have a pump available, and you're going to have to actually figure it out through another method, whether it's counting drips or just evaluating the patient's response to what's going on. And then for Ativa, it's usually going to be 100 to 300 mics per kilo per minute. You'll see, especially for pediatric patients, it tends to be towards the 150 to 200 mics per kilo per minute range. And again, part of that comes into play is what other medications the patient's getting. If you're mixing ketamine in with this, you may be able to decrease the dose of propofol they're getting. If they're getting fentanyl or Precedex or something like that, all those will allow you to decrease the amount of medication you're giving. So I put here it's not a controlled substance, but as I said, local practice may dictate that it is. So just be familiar with the practice there. You will see that there's pain with the IV pushes. If you've ever had an IV, it just feels kind of weird no matter what medication they're pushing. So the pain may not just come from propofol. You may see like etomidate is also very painful. Rocuronium is painful. So a lot of these patients will go ahead and give them a bolus of lidocaine as pre-treatment for the burning from the propofol, but it also helps block the sympathetic stimulation from the laryngoscopy. A lot of times you don't have to decrease your doses in any sort of renal or liver disease patients, but you will wind up decreasing it in the elderly patients. Pediatric patients may require a little bit more than adults usually do. So remember that high point for your MACA being like 6 months. So nice things about propofol: patients generally unconscious in about 30 seconds. If you start administering propofol and you get to that 30-second window and they're still looking around, go check your IV. More than once, I've had an IV that came out in the middle of induction, and patient should have gone to sleep, didn't go to sleep. I look down there and they've got this big propofol hematoma. Or it may be somebody that just requires extra medication. I've had patients for colonoscopies with great IVs that took like 400 or 500 milligrams of propofol before they finally went out. And these are people with clean drug screens. So sometimes patients surprise you. I think as we start getting further and further into studying genetics, we'll figure out that there's like some gene that makes these patients require a little bit more anesthesia. Elimination halftime is 30 minutes to an hour and a half. So if you've got somebody that is on Ativa, especially if they're on like that higher dosage, 150, 200 micrograms, start taking that into account. So it's going to take a little while for those effects to go away. You can't just turn your propofol off and they wake up magically. So you have to kind of start planning where are they at in the case, because you don't want to get burned on your patient not waking up because you didn't turn your propofol off. With that being said, it's probably going to happen to every one of you at some point. So just try and avoid it if you can, but when you do, you'll learn from it and move on. Other thing, you'll see if you have a long case, generally more than about 40 minutes to an hour, you start to see patients having accumulations. So think about those patients that were in the ICU on propofol for days. They were usually on pretty low dosages, right? Compared to this, they were on like 40, 50 mics per kilo per minute. So if you have somebody that's getting like a long spine case and they've been on 200 mics per kilo per minute, it's going to take that patient a lot longer to wake up than just somebody that had a Tiva going for an hour. So high doses for long periods of time are going to take even longer to wake up just because they do accumulate. Other things to think about with your propofol: it's a bronchodilator. It also helps suppress the sympathetic response to laryngoscopy. It's the best medication we use to do that, but things like lidocaine and fentanyl also help. And as I mentioned, propofol is a great antiemetic. So you can use it as a rescue medication in low dosages. A lot of times what I'll do at the end of the case is have a cc or two of propofol left. I'll take that with me to recovery. So if the patient does happen to become nauseated on the way over there, I can give them that last cc or two. And usually that's enough to make the nausea resolve. The other thing you'll see is if you have somebody that starts acting the fool on the way to recovery, it's kind of nice to have something to put them back down. And usually that cc or two is enough to knock the edge off without having any sort of like respiratory depression and that sort of thing. Sorry, Tyler, I missed your question earlier. You will see that MAC bar, as far as an actual number, varies from one place to another. Usually it's greater than 1.3 MAC, just because as you start looking at the standard deviation, that's when you should hit about 95 to 99%. Problems you may run into with propofol. Patients that are on it for long periods of time, again, this is usually in the ICU and on large amounts, tend to develop some kind of fatty liver syndrome or hyperlipidemia. So they'll start to have enlarged liver. As part of that, they get fatty infiltrates. They'll become metabolically acidotic. You'll see that they go into rhabdo, and then they may also develop myoglobinuria. If you look at their urine, they tend to develop like this green urine. Collectively, that's referred to as propofol infusion syndrome. But what you may also see is that patients that are on large amounts of propofol for long periods of time will start developing bradycardia. And there have been a couple cases of sudden onset of bradycardia that quickly progressed to asystole. So for the longest period of time, we used propofol as like our go-to sedative in the ICU. And over time, we figured out that we may be causing some problems with propofol as a solo agent. One of the biggest ones that would drive me crazy is you'd have somebody that got propofol and now they're hypotensive. So now we're having to put them on Levophed to counteract what we've done to them. On the other hand, if you used more of a balanced approach with like fentanyl propofol or ketamine fentanyl or some of those sorts of things, you can achieve the same sedation without affecting your blood pressure quite as much. All right, so we're going to move on to etomidate. It's a GABA agent, and as part of that, what winds up happening is that it's very lipid soluble. Primarily used for induction, it's a cardiac stable medication. It can induce seizures, so while you can use propofol and ketamine to treat seizures, etomidate can actually cause seizures. You'll see that it can also cause muscle spasms. One of the biggest ones we worry about is master spasm. So you give the patient etomidate for intubation, and they tend to, not tend to, but they can have master spasm where they just bite down for you. I primarily use etomidate for my cardiac cripple patients. So somebody with a really sick heart, I'll use etomidate, and that's about the only time I do it. I may use etomidate as an induction agent if I'm doing like a EGD or colonoscopy. What I'll do for those patients is give them a bolus of etomidate to knock them down, and then I'll use propofol to kind of keep them sedated. Dosage-wise, 0.3 milligrams per kilogram. The textbook says there's no change for sick patients, but you may see that it's reduced for some people anyways. It can be painful on injection. Like I said, etomidate's painful. Rocuronium's also painful. There are some articles out there that reference etomidate causing adrenal suppression. Part of the studies were patients that were getting multiple doses of etomidate. One was even patients getting etomidate as an ongoing infusion for sedation in the ICU. So it's probably not as horrible as it's been made out to be, but the one thing that is overall clear is the adrenal suppression. Again, it's dose dependent, but if you have somebody that's already sick, which is the reason you're using etomidate, and then you cause adrenal suppression, it's probably not going to be good for them. And it lasts for a while, like 4 to 8 hours. And we've seen that even in patients that get steroids after etomidate, it doesn't seem to really help. Just another caveat for you as far as etomidate, it can also cause PONV. You may hear people refer to it as vomitate, because out of all of our induction agents, it's the worst as far as causing PONV, about 30% of patients. Moving on to ketamine. it's a dissociative anesthetic. It's not a hypnotic agent. So you may see that if you give somebody a large amount of ketamine, that it's like the lights are on, but there's nobody home. You'll look at their eyes, and they tend to have nystagmus. In a perfect world, they continue to breathe. They just lay there nice and quietly. The nice thing about it is it's a very potent amnestic agent. It's the only medication we use that causes anterograde as well as retrograde amnesia. Problems you can get into with using ketamine. We discussed ICP stuff a minute ago. But the other thing you may see is that sometimes if it's given rapidly or patients have already gotten a large amount of opioids, it may be enough to kind of tip them over to where they do have some respiratory depression. Otherwise, it's about the safest anesthetic agent we use. It disassociates the patient, it provides analgesia, but you generally don't have any sort of respiratory depression. We're using it for a lot of different things right now, chronic pain infusions, PTSD as a non-opioid analgesic. Comes in a variety of preparations. With that being said, the most common one you're going to see is 50 milligrams per ml. It doesn't burn on injection. So it's kind of a nice medication to use as you get comfortable with it. But it at first can be a little bit troublesome for you because it's not as simple as some of the other medications we use. So for induction, generally we're going to use 0.5 to 1.5 milligrams per kilogram. As I said, the 1.5 is kind of the standard dose, but if you've got somebody that's really sick, you may consider decreasing it down to the 0.5. Pretty quick onset, about a minute. As far as anesthesia, you usually get about 10 or 20 minutes out of that large dose. So that buys you a little bit of time for giving something else to follow up or getting your gas going. You may see some extrapyramidal symptoms that result in the patient, but they're not very common, especially if you're doing this as a general anesthetic agent because it's usually masked by everything else. As a standalone anesthetic, you can use, our analgesic dosage is usually like 0.2 to 0.5 milligrams per kilogram. Because it is more concentrated, you can also use it intranasal. So like if you've got a patient that's in pain, but you're having a hard time getting an IV in, you may be able to give them some intranasal and help them relax a little bit while you're getting that IV in. I put it down as catch the kid, but a lot of times if you've got a pediatric patient that's running down the hallway or maybe somebody with some MR, we'll do a ketamine dart, which is usually a combination of Versed, Robenol, and ketamine. And it's enough to help achieve that disassociation, not have to chase them down the hallway, and then you can get your IV started. A lot of times when I do pediatric dental cases and like freestanding centers, we won't have an anesthesia machine, so we don't mask the kid down. What we'll do is give them that ketamine dart, and then it calms the kid down. We can start an IV, and then we'll start propofol for them. Generally gets you about 5 or 10 minutes of effect. The one thing you do have to watch for your ketamine, especially in high doses, it will increase secretions. So for like these pediatric patients that are already prone to laryngospasm, it's kind of nice to have that glycopyrrolate in there. If I'm using ketamine as part of a sedation case, a lot of times what I'll do is give them some Benadryl instead of Robenol, because I get those same drying effects, but they also get a little bit of sedation out of it. No pain as far as on injection. It's pretty high clearance. It's very low protein bound. Generally what you see is that it's redistributed pretty quickly and eliminated in a couple hours. So it is one thing you have to think about. If you've got large dosage for the patient, it may stick around for a little bit longer. You know, the plus side is if it sticks around a little bit longer, it's not really a big deal. It usually doesn't cause respiratory depression. Where you can get into trouble is if you do give large dosages and you have somebody with like emergence delirium, it may go on for a little while, so you may actually have to treat them with something. Contraindications, avoid in patients taking AMAOIs because you do have increased circulating epinephrine. So one of the big things that we worry about with ketamine is that delirium. With small subanesthetic doses, it's extremely rare. Where this came from in the past, we were giving like 4 to 5 milligrams per kilogram. And in those patients, we would have emergence delirium pretty regularly. For the subanesthetic doses, like for giving it just for analgesia, it's usually not a problem. With the induction dosage, especially if you do like the 1.5 to 2 milligrams per kilogram, you may see that post-op or in PACU they have issues. Some patients will think it's the worst thing ever. Other people think it's great. I usually do not give ketamine as a standalone agent. So if I give ketamine, I almost always give Versed or Precedex. That way they've got a little bit of calming effect. And with that in mind, I've not had a whole lot of trouble as far as emergence delirium. From a cardiovascular standpoint, you get increases in almost everything, which is kind of nice for that shocky patient or a patient that's doing poorly. You don't get any real respiratory depression because they are dissociated. Their airway is not really protected. So like I said, secretions can be a problem. One of the nice things with ketamine, it's a pretty profound bronchodilator. So you can use this to treat asthmaticus. You can also use volatile anesthetic agents to treat that too. But that means we've got to get the anesthesia machine to the ICU or the patient to the OR. So if you have an asthmatic patient, you may consider adding ketamine into your treatment regimen just to help bronchodilate them. As I mentioned, you do have increased secretion, so consider pre-treating with Robenal or Benadryl. Generally, the laryngeal and pharyngeal reflexes are intact. You're just disassociating the patient. So sometimes I'll use ketamine when I'm doing an awake intubation, and it helps maintain that muscle tone, so it may be a little bit harder for you than, say, something like propofol. But the nice thing is you don't have the problem of the tongue falling back into the airway. As I mentioned, you may have some hallucinations with ketamine. It's not real common in the lower dosages, especially if you go ahead and give it with like benzodiazepines. Some people will always give Versed or Valium with it. You can also give barbiturates or propofol. Just keep in mind there may be a reason you were using ketamine because the patient couldn't tolerate propofol or barbiturate. Dexmedetomidine, it's not a like true induction agent. I just included it here because there's not a real good place to put it otherwise. Also known as Precedex, it's an alpha-2 agent. Primarily what it does is turns down the sympathetic system. So if you're trying to think of an easy way to think of it, that's it. So by turning it down, you get some sedation, you get a block of the sympathetic drive, you tend to get bradycardia, especially in boluses. You get a variety of alpha effects. So the one we're really hoping for is the sedation. Along with that, we also get some hypnosis. And then from blocking the surgeon's effect on the patient, we also get a sympatholysis. You may see that there's some vasoconstriction. It works very well for shivering. For a long time, the only real medication we had to give patients shivering and recovery was Demerol. Now you may be able to use Precedex for that as well. Either as a standalone or in conjunction with other medications, it works pretty well as an analgesic. Primarily, we use it as a TIVA agent, but over time, it's become more common to use as far as an adjunct for everything. As we've gone away from using quite as many opioids, you'll see that a lot of times we'll administer ketamine, Precedex, lower dosages, as opposed to if you think back to the ICU, those people were usually on an infusion. In the operating room, we may give a bolus dose, or you may just work in like 20 to 40 micrograms over the course of the case. So it's a little bit more stable for the patient. Preparation kind of varies. Usually it comes in 2 ml vials. It's 100 mics per ml. And then you're going to mix it in either 50 or 100 mLs of saline. If you go up to 100, just make sure you increase the amount of medication you're adding to it. The standard concentration for it's going to be 4 milligrams or 4 micrograms per cc either way. So as far as dosing, the standard loading dose is 1 mic per kilo over 10 minutes. You'll see if you bolus this too fast that it tends to cause bradycardia and hypertension. But if you do it either on a pump or just push a little bit slowly and spread it out over that 10 minutes, you generally don't have this problem. If you're running it as an infusion, the standard rate is 0.2 to 0.7 mics per kilo per hour. The one thing you have to think about when you start getting into all these infusions is it becomes kind of a logistical problem for you. You've got to have pumps. and you've got to set up those pumps. And then as far as like getting them connected, getting them started, that sort of thing, it's a little bit of extra work for you. So that's why a lot of times you'll see that Precedex is being given as a push as opposed to putting it on a pump. The other problem you run into with Precedex is it's expensive. So some hospitals have kind of looked at creative solutions to that. One of them is instead of everybody mixing up a bag of Precedex, which you're probably not going to use the whole bag, hospitals will go through and draw up syringes that may have 20, 40, 100 micrograms in it. And that way they can spread that over several cases as opposed to just one patient. And usually that's done in the pharmacy, so you don't have to worry about it. You see that done sometimes with ketamine as well. Ketamine's not expensive, but that way you don't have the medication wastage for it. Looking at questions, Nathan asked, is it okay to use propofol as a rescue medication when it's already been used for induction? Yes, definitely. You may see that you have to use even more propofol for induction depending on the patient, or maybe intraoperatively the patient gets light and you have to draw up and give some more propofol to sedate them while you're waiting on your volatile agents to take effect. So a little bit more about Precedex. The nice thing about Precedex is you don't have a whole lot of respiratory depression from it. The caveat to that is that if you have given large amounts of opioids, the Precedex may exacerbate those effects. So if you had somebody that maybe had a little bit of respiratory depression from just the opioids alone, and then you give them Precedex, you may see that they have a lot of trouble breathing. They're not necessarily distressed, but you will see them hypoventilate over in recovery. Another nice thing about Precedex, especially if you're using in combination with ketamine, is it tends to dry up secretion. If you have somebody that you're worried about obstruction, maybe they've got a big tongue, they've got redundant tissue, Precedex will exacerbate that. So generally, if I have a large obese patient or somebody that has sleep apnea, I will either go light or avoid Precedex because I don't want to have respiratory complications, especially PACU, because it tends to stick around for a little bit longer. Those patients, especially like on emergency, you really want them as awake as possible so they're able to protect their airway. As I mentioned, you don't have a whole lot of respiratory changes, so usually your ABG is going to be normal. You don't have a whole lot of changes in tidal volume or respiratory rate with just Precedex. If you're using it, like I said, with opioids, you may see kind of an intensification of effects. Other things, it tends to widen the thermoregulation curve, so it works well for preventing or stopping shivering. One of the things when we were using large amounts of fentanyl for induction, we would see some muscle rigidity. Precedex helps out with that. This works really well for polysubstance abusers because you're able to offset their withdrawal from the medications. And with it, just a side note with that, we always talk about like opioid withdrawal. Opioid withdrawal is not really a life-threatening emergency. It's uncomfortable, but alcoholic withdrawal can be extremely dangerous. And for a while, they were doing treatment regimens where they would put people under anesthesia and let them withdraw from alcohol. And what they found was that other methods that it was almost 50% fatal, whereas using Precedex, they had pretty good outcomes. Patients that are on chronic pain treatment regimens, primarily gabapentinoids and opioids, start to become extremely tolerant of medications. You may see that Precedex works pretty well in those patients because they're not getting a whole lot of alpha agents. The one caveat to that is that if you have patients that are taking like clonidine, PO, or as a patch, you may not see quite the same effects that you would on somebody that's alpha blocker naive. Older medication you may run into, methotrexate or Brevital. It comes in a 10 or 20 milligram solution per ml solution, so make sure you know what you have. With that in mind, it usually comes in 50 mLs of 1%. Adult dosage is, or pediatric dosage for that matter, we don't use it a whole lot in kids just because it doesn't work that well. 1.5 milligrams per kilogram. Pretty quick distribution time, and it clears pretty quickly as well. The downside is even though the intended dose will clear pretty quickly, that overall it sticks around a little bit longer. So they don't have the same therapeutic effects for that 4 hours, but you may see that they still have some sedation for quite a while. Excuse me. Low doses can cause myoclonus and hiccups, and it may cause seizure activity as well, which is kind of weird because at low doses it will cause seizure activity, but high doses are actually able to treat seizures. Common pattern you'll see methotrexate used for if you go someplace and they're doing ECTs where they're treating psychological problems is pretty common to use Brevital for those patients. Downside for us, it is an airway irritant, so we don't use it quite as often as we used to. But again, like I mentioned, with weird medication shortages, you may see that something that we weren't using before comes back into play. So like I said, big things, quick, non-painful procedures. So like ECTs are a big one. And the reason for that is because it's not going to depress the seizure in low dosages. Again, remember in high dosages it may. It works out pretty well for cardioversions. Again, it's a pretty quick, non-painful procedure. And then something where they're trying to actually map where seizures are going on, because it doesn't blunt the seizure foci. They're able to actually see where it's originating. All right, we're going to transition over to narcotics. Morphine is kind of the standard we use for everything, so we're going to start off with that. It's an opioid. Pain dosage is generally 5 to 20 milligrams, and it's titrated in. So you may give somebody 20 milligrams over a period of time. Usually you're not going to give them 20 milligrams at one time. That would probably be bad for your patient, but somebody with like severe burns or something like that may do okay with it. Because it takes a while to metabolize, especially if it's given intrathecally, you may see that you have the potential for respiratory depression for long periods of time. You get a dose-dependent histamine release. So if you have somebody that is maybe already hypotensive, it may not be a good agent to use because when they get that histamine release, they're going to vasodilate. You can give Benadryl ahead of time to try and blunt part of the histamine release, but you may still see that there is some effect. High doses tends to decrease your pulmonary vascular resistance. It's got 2 active metabolites, and as part of that, you start to see a prolonged half-life in patients that are elderly and have liver or kidney failure. Dilaudid or hydromorphone is kind of like morphine's big brother. It's 7 times more potent than morphine. And one thing you'll see for the opioids, depending on what source you look at, there's varying ratios as far as the potency, but they're all pretty close together. Advantage of Dilaudid, it causes less histamine release. Takes a little bit longer for onset and to peak effect, but it also lasts quite a bit longer. You see anesthesia providers a lot of times will use this towards the end of the case because it not only covers the patient intraoperatively, but when they get over to recovery, they're usually comfortable as well. It's very potent, so lower doses are needed. So if you think about it, back to our morphine, we were doing 5 to 20 milligrams. With Dilaudid, you'll tend to see like 1 to 4 or 1 to 5 milligrams. And sometimes that's administered as increments. So you may give a half milligram or a milligram and just continually give it as opposed to kind of firing it all out there at one time. The other thing, like I said, you have to worry about delayed response. So patients may be doing fine with it intraoperatively while the surgeon's still cutting on them. But when there's no more stimulation, you may have a hard time arousing them, and you may see some respiratory depression. Fentanyl is the most common opioid we use intraoperatively, especially as the trend has been towards less opioids and lower dosages, just because it's got a faster onset and a shorter half-life. It works a little bit better for us in the operating room. You don't have to worry quite as much about the long-term effects that you see with everything else. From a dosing standpoint, again, there's quite a range. 1 to 3 to 5 mics is the most common. Usually we try to front load our patients with opioids. So we'll get them kind of comfortable for the first hour of surgery and then let the patient kind of drive what you do after that because they may not need anything else, or you may see that you need to redose the patient. Sometimes we'll use fentanyl as an infusion. So like as part of a TIVA. In that perspective, it's usually like 3 to 6 mics per kilo per hour. One thing for thinking about any of your opioid infusions, and it varies a little bit as far as how long, whether you're using like fentanyl or sufentanil or remifentanil. It's going to cause respiratory depression. So you got to think about an hour out before you want them breathing and turn your medication off. Standard concentration is 50 micrograms per ml. Most commonly in the operating room, we'll either get a 2 mil vial or ampule. There are also 5 mil, and then there are also 20 mil vials. Generally for the 20 mil vials, you're only going to see those like in the cardiac room. But if you're mixing your own infusion, that may be something that's a little bit easier for you. For elderly patients, decrease your dosage. Dose the medication off the ideal body weight. And as I said, it's kind of the mainstay as far as our intraoperative anesthesia and analgesia. We use fentanyl for almost everybody. Meperidine or Demerol is an opioid agent that we don't use quite as often as we used to. As I mentioned earlier, the most common times you're going to see it now are going to be for postoperative shivering. And then there's still a lot of places that use it for pediatric patients for their analgesia. So you may just give like a one-time dose of Demerol for somebody getting tonsils or adenoids done. For adults, the dosage is usually 6 1/4 to 12.5 milligrams to try and treat their post-op shivering. Pretty fast onset. It lasts for 2 to 4 hours. One thing you have to worry about with Demerol, its active metabolite, normoperidine, can cause seizures because it's a CNS stimulant. So if you have somebody with a seizure threshold, you want to make sure you avoid giving meperidine. If you have somebody who's taking MAOIs, avoid giving meperidine because of the block of the reuptake of serotonin. And as I mentioned, our biggest thing is going to be for shivering or shaking, post-procedure, post-anesthesia. Sufentanil is an opioid that it's kind of a hybrid. A lot of times we'll use it as an infusion, but you may also see it given as a bolus as well. So if you're giving it like as a bolus, it's usually going to be 0.3 to 0.5 mics to 1 mic per kilo. Some people will use that as part of their induction regimen. So you may see that they give a mic per kilo of Sufenta, and then depending on the case duration, they may not give any other opioids at all. If you're using it as an infusion, it's usually like 0.5 to 1 mic per kilo per hour. Again, remember, it's going to take a while to wear off. So if a case is like shorter than 2 hours, usually about 30 minutes turning it off before they'll breathe. If it's longer than 2 hours, because they do get some accumulation, you may see closer to 45 minutes to an hour. Again, it's supplied 50 mics per ml. One of the biggest reasons that we use Sufenta is long cases that patients need an analgesic. So think about sometimes for cardiac surgery, a lot of times for ENT or OMFS cases, like if they're doing a flap or a mandibulectomy, some of those cases will use Sufenta infusions because it keeps the patient comfortable for a long period of time. The other advantage of this is it kind of goes away a little bit quicker than fentanyl does, but it stays around a little bit longer than remifentanil, which we'll talk about in a minute. But the thing you have to remember with this and Remi especially, because they are going to go away, they're probably going to need something in recovery. So sometimes what we'll do is run patients on an infusion of like sufentanil or remifentanil, and then towards the back end of the case is we're letting the infusion wear off. We'll give them fentanyl or morphine or Dilaudid or something like that for pain and recovery. So moving on, Remi is kind of the short-acting opioid. If I kind of remember, Altiva is like ultra short acting. You can use this as a short-acting opioid as a bolus, like 0.5 to 1 mics per kilo or mics over a minute. It's supplied as 1 to 2 milligrams per vial. For your infusion, you can look at like 0.1 to 0.4 to 0.5 mics per kilo per minute. A very short half-life. So if you think back to like fentanyl we were talking about, you need to turn it off about 60 minutes before they breathe. Sufenta, 30 to 45 minutes. With Remi, you're really looking at like 6 to 10 minutes. So very short half-life. Part of that is because it's independently metabolized by plasma esterases. So it's not real dependent on organ function. things that come along with REMI, which may be good, they may not be. You get very quick respiratory depression. So sometimes if you have somebody that you're doing a short case on, but you don't want to use succinylcholine, you can actually use remifentanil to induce respiratory depression in lieu of a neuromuscular blocker. One thing you do have to be cautious of is that it will cause bradycardia, especially in those large dosages. If you're running a drip, you're going to see a pretty significant reduction in your MAC value. So say, for instance, I was doing a spinal case and I wanted to do kind of a half MAC of gas and then some TIVA. You have a pretty significant reduction in that gas demand if you're using especially higher doses of remifentanil. Where do we use it? Primarily, it's going to be TIVA cases, most of those being neuro stuff, cranies, backs, carotid endarterectomies. We use it some as well. And part of the reason we're doing it for carotids is it keeps the patient very sedate, very comfortable, very CV stable, but it also goes away quickly. So one of the things we worry about with carotids is that they've potentially had a stroke intraoperatively. So that allows the medication to go away rapidly and get a full neuro evaluation on these patients. Another thing for you to think about, like I mentioned, on the post-op end, they're going to need coverage for pain with something else because the quick on, quick off. And then finally, kind of the biggest thing you have to deal with REMI is it's very expensive. So part of the reason we don't use it for everything is cost-wise, you're kind of throwing money out the window. So as far as like hierarchy of cost, REMI is the most expensive. Sufenta still costs more than fentanyl, but it's not nearly as expensive as REMI. And then when you start getting down to fentanyl and morphine, a lot of those are significantly less expensive. So keep that in mind. And as part of that, just be cautious. We generally try not to use it any more than we have to. And we also make sure if we get it out that we're really going to do the case before we draw up the medication. You'll figure out when you get to the operating room that some surgeons are notorious for showing up late or canceling cases last minute. This is one of those cases you want to make sure it's going to happen before you drop the medication. All right, we're going to talk a little bit about kind of the whole morphine family. And what you're seeing here is stuff that's given PO as well. So you'll see we can give morphine PO. Dilaudid is also available in a PO formulary. And then stuff that we weren't really using in the hospital from an anesthesia standpoint, we're starting to see used more and more. And it's kind of interesting as we've gone away from so many opioids, we've gone away from short-acting opioids, and we may give patients something that lasts a little bit longer. So like an oxycodone or a hydrocodone PO pre-procedure, and then they don't wind up having to require any opioids intraoperatively or post-operatively. So you're reducing the overall amount of opioids that are given by giving a PO formulation up front. Codeine is mixed in with all sorts of things. We've kind of gone away from codeine. For a long time, we were giving it with cough syrup, with Phenergan, with all sorts of stuff. But we know because of the delayed effects of it, that especially in pediatric patients, we were seeing a lot of respiratory depression and recovery. And then even those that were going home with it were having problems. So we kind of backed off on giving codeine. And then finally, we've got tramadol, which we use also kind of as a long-lasting pain medication for patients. Other thing you'll see is that there's a lot of partial agonist, antagonist drugs. So like methadone, Stadol, Nubane, buprenorphine. These drugs are primarily used either in the emergency room for treatment of addicts or for some obstetric patients. The nice thing for those patients, you'll see a lot of times when people get spinals, they'll have post-procedure itching, especially if they had opioids in their spinal or epidural. So you can give them like Stadol or buprenorphine or Nubane and help treat the itching without reversing the analgesic effects. You may see methadone used in the operating room if you have patients with chronic opioid therapies. So sometimes what will happen is you'll have patients come in and we'll go ahead and give them like a 10 milligram dose of PO or IV methadone. And same thing, they're usually covered for the whole case as opposed to having to give them short-acting opioids. So now we're going to go to the other end of the spectrum. You've got a patient that for some reason is experiencing respiratory depression because of our opioids. So we're going to consider giving them Narcan. Sorry, I'll flip through the questions real quick. Fentanyl infusion dose. Really, you're going to see some variation there. Flip back to it for you. So this is a weight-based dose, Tyler. 50 to 150 mics may be trying to figure out where you would have come up with 50 to 150. I'm not sure. That would be a pretty high dose. Yeah, maybe 50 to 150 mics per hour, like overall, not as like a weight-based dose. Yeah, like in the ICU, you would use like 50 to 150 mics per hour as a dose for sedation, but not like weight-based. All right. So back to Narcan. It's a pretty wide receptor antagonist. Primarily in the operating room and anesthesia, we use it to reverse respiratory depression, usually that we've caused. It's usually supplied 400 mics per ml. And the way we handle that in the operating room, if you ever like worked ER, you guys would give like 2 milligrams or a milligram or 4 milligrams. We try and kind of tailor our response for our anesthetic patients because, as I said, usually we've caused this. So we've given them opioids. And as part of that, they've developed some respiratory depression because maybe we gave them a little bit too much. It's not an exact science. We thought the patient needed X amount and they didn't. So we want to try and get them breathing again without causing them to have all the pain back that we were trying to prevent. So what we usually do is take that 0.4 milligrams or 400 micrograms and dilute it down to 10 mLs, which gives you a concentration of 40 mics per ml. And then we'll start administering it like 40 mics at a time or 1 ml at a time. And we're going to give a mil, wait and watch and see what happens before you give another one. Because you want them to have that return of respiratory function without undoing everything you've done. So that's the easy way to do it. If you have somebody that's apneic, you can always ventilate them until you get the return of respiratory function you want. The more common scenario is it's like the end of the case, and especially when you first start off, you've given too many opioids, and now you want to slowly work it back to where they're breathing a little bit better. So sometimes what you'll see is that they're breathing, but the respiratory rate's very low. And when I say very low, I mean like 2 or 4 a minute. You'll see people that are comfortable, especially like if they've gotten a sufentanil infusion and they haven't quite returned from it yet, may only be breathing like 8 to 10 times a minute, but they generally have a large tidal volume that makes up for it. So again, think about it in terms of minute ventilation as opposed to just one tidal volume or one respiratory rate. If you have somebody that you abruptly reverse their analgesic effects, you tend to see a whole lot of things happen. Cardiac stimulation is kind of the nice thing. What's really going to happen is they're going to become tachycardic, they're going to become hypertensive, and a lot of times they're going to become violent. Whether they were violent to start off with or it's just because of what's gone on, they go from being very sedate to having an overwhelming amount of whatever the stimulant was. So if they just had surgery, now they have excessive pain. So that's why we try and do the gradual reversal as opposed to the 2 to 4 milligram bolus you probably did before. One of the things you will see if you do a high dosage is the potential for flash pulmonary edema. Low dosages generally prevent that from happening. The nice thing, and one of the other things you may see, and part of the reason we give it, is to treat some of the mu-related side effects. So the itching, the urinary retention, the muscle retention, and the biliary spasm. As I said, the downside of giving a straight antagonist is that you reverse everything, whereas some of the agonist-antagonist, you can still have part of your analgesic effects, but also treat part of the side effects we don't want. One thing you really have to watch is that giving Narcan may be great for the patient, but it may also wear off before the narcotic does. So you may see somebody that has re-effects or goes back into respiratory depression. after getting narcotics. So make sure they're monitored, especially if you're giving long-lasting opioids. It's not something we do very often in the operating room because we're generally pretty cautious about how we give our medications. But kind of the worst case scenario, you give somebody X amount of opioids, they go to recovery after you give them Narcan. The Narcan wears off, and then either in recovery or they go up to the floor and start having problems. So one of the things you need to make sure when you take somebody to recovery is you communicate that the patient's gotten Narcan. They may have to stay in the recovery room for a longer period of time. The standard kind of varies from one place to another, but they'll usually keep them there an extended period of time to make sure they don't have any sort of reaccumulation, because you can imagine how devastating that would be. Yeah, Katie, for Dilaudid, usually I'll give 1 to 5 milligrams, a half milligram or so at a time. All right, moving on to benzos. And we use benzos for a wide variety of reasons in the operating room. The most common one we think about is preoperative sedation, and the most commonly used agent is Versed. And we use that for sedation and help a little bit with anxiety. But you may see that you have to give it for other reasons as well. I'll give you an instance. I had a lady yesterday, I was covering regional, history of polysubstance abuse, had an infection in her hand and index finger. So they'd already done the procedure. They called me over to recovery because they just couldn't get her comfortable. She'd already gotten Dilaudid, she'd gotten ketamine, she'd gotten fentanyl, all sorts of stuff intraoperatively, and they wanted us to block her. So I went ahead and blocked her, and they called me about 20 minutes later to come back over because she was still having pain. And I knew from the block that great anatomy, good visualization. It wasn't really a pain problem. This is probably more of a psychiatric or supratentorial issue. So gave her a half milligram of Ativan. She relaxed. All of a sudden, her arm was numb, and she felt great. So you may see that benzos come into play for a lot of different reasons, other than what you really think of. Some patients may require more than others. Other things that may come into play, you may have to use your benzos as an anticonvulsant. People have seizures all over. Sometimes we cause seizures. Sometimes patients cause seizures. Sometimes they're not real seizures at all. But you may have to administer benzos for that. The other thing you'll see is that sometimes we'll use them as part of our anesthetic because you do get some profound muscle relaxation with large dosages. So this is just kind of a breakdown as far as the potency for you. Ativan tends to be the most potent, followed by midazolam, followed by diazepam. One thing you run into as far as Ativan goes, it generally has to be refrigerated, and it's very thick. So it may not be quite as plentiful as midazolam. As far as kind of the hierarchy there, Ativan's generally about 5 times more potent than Versed, and Versed is generally about 5 times more potent than diazepam. So an easy way for you to think about this is that, Versed, we usually give like 1 to 2 milligrams. Valium, you usually give 5 to 10, so about 5 times there. It doesn't hold true for Ativan because you're still giving like 1 to 2 milligrams of Ativan and 1 to 2 milligrams of Versed. But just something for you to think about there. So kind of nice things about benzos, you generally have little cardiac activity from it. So if you're just giving a sedative dose, it's not usually a problem. If you start giving kind of the higher end sedative doses, you may see a little bit of blood pressure decrease, but it's pretty minimal. It again also depends on the medication you're giving. Usually you don't see so much with Valium, you do see more with morphine. You do tend to have pretty significant respiratory depression. Sometimes that's what we're going for. So think about somebody that maybe you're using like midazolam as your induction agent. I don't care if they stop breathing because I'm making them stop breathing either with that or another medication as well. You do tend to see depressed respiratory effort, airway reflexes, and ability to swallow. So somebody you're worried about them obstructing, you may see that benzos tend to make it worse. Their hypoxic drive is also depressed. So if you've got somebody that you're worried about them breathing and you give large amounts of benzos, you may see that they don't breathe quite as well on the back end of the case as you want. This is one that's been in the news recently. Any dose with any patient can cause apnea with any of these benzos. Midazolam tends to be the worst. I'll give you, for instance, my wife's kind of a lightweight apparently. She was getting surgery on her thumb, got a milligram of midazolam, went unresponsive and almost apneic. You never would have expected that, but healthy person. So now imagine somebody old. I've seen patients that were getting a half to a quarter milligram of midazolam for analgesia while their art line was started, and they went apneic. So if you're going to administer any sort of benzo, you need to stay there with the patient. They need to be on continuous pulse oxes because you're setting yourself up for something devastating if you give them Versed and walk away. Some places we will give the pre-op Versed. Some other places the pre-op nurse may give it. So just be familiar with whatever the practice there is and make sure the patient's being monitored or you stay with the patient. They don't necessarily have to be on a pulse ox or a cardiac monitor if you're standing there looking at them, but it probably doesn't hurt. You'll see that in conjunction with opioids that they tend to be very synergistic. One of the things that benzos do not do when we start thinking about induction agents is it doesn't blunt the sympathetic response. So you generally will still see tachycardia and hypertension if you use a benzo as your induction agent. If you're just using PO medications, PO Valium and PO Ativan generally have no respiratory depression if they're just getting that. But what you have to watch is that they get PO Valium and then they also get gabapentin and then they also get some sort of opioid. Because a lot of times patients are not just getting one of those medications, they're getting several of them. So the good news is we have a reversal agent available for the benzodiazepines. With that being said, we almost never have to use it from an anesthesia standpoint because we time our drugs and don't have to worry about it. If you think about when we get benzos, it's usually upfront at the beginning of the case. So whether it's a 30-minute case or a 3-hour case, usually the benzos are pretty gone by the time the patient gets to recovery. But if for some reason you continue to have respiratory depression after you've kind of eliminated everything else, you may consider reversing your benzodiazepines. Again, like I said, low dosages are generally not a problem. But as far as the reversal goes, it's going to be 0.2 milligrams IV, which is pretty fast. It's not as fast as Narcan, but you'll see it's pretty quick onset. Usually it comes supplied 0.1 milligrams per cc, rapid onset, and you may redose it to a total of 1 milligram. But one thing for you to think about, if you haven't given that many benzos and you've reversed this, start thinking there could be something else going on. One of the big things we'll see is that, we start kind of working down the differential list, patients unresponsive or they're hypoventilating post-procedure. All right, so usually we start off, we give them some Narcan. That doesn't really seem to change anything. We may consider giving them some Romazicon. That doesn't really change anything. Other things you need to think about, make sure their blood sugar is not low. Could be a diabetic problem. Make sure they've gotten all the gas out of their system. Make sure they've had full neuromuscular reversal. So think about all these things. And then finally, the other thing is start thinking about what else could have happened. Did this patient have a stroke intraoperatively? We don't want to be sitting here fooling around with all these other things for hours while the patient's had a stroke and could be getting therapy. So if it's somebody you think it may be a benzo problem, certainly treat it. But always keep in the back of your mind, it could be something else as well. All right, we're going to stop right there for today. We'll catch back up with nausea and vomiting agents next time. What questions do you guys have? All right, Matt's got to pee. Hopefully he didn't pee on himself. No, we're not going to finish today because we've still got to go over a bunch of other stuff on the drug formulary. I mean, we can finish the lecture, but we're still going to have to go over stuff. Does everybody want to finish, or is it just Katie? Yeah, class on Thursday will not be quite as long. We're going to finish up the slides. And then there's some other stuff that didn't fall into this that we need to go over.
as far as like non-opioid anesthetics. We're going to talk about antiemetics, a lot of your cardiovascular medications, your infusions, and that sort of stuff. And then kind of situations you run into things that you might have to treat. So I'll let you guys decide. We can finish today, but we're still going to have stuff to do on Thursday, but I can finish the lecture. All right. So question, the exam is going to be based on the slides and the clinical guide. Yes, it's going to be based on them both. And as I said, part of this is going to be just a reference point for you. So you may see some variation of things. But yeah, this is a good jumping off point for you. And I try not to make the questions too difficult for you. As far as like, I understand that you really don't have any exposure to being in the operating room with it yet. So you're just kind of thinking about things. Abby asked how many questions. I haven't finished it yet, so I'm not sure. Let me look and see what I had. I'm thinking it was 50. I had 40 questions last time. It'll probably be 50 this time. Yeah, probably 50 questions on the exam this time. Or 46, something like that, 48. All right. Tyler's asking, on ketamine, it says responsive in 30 minutes due to redistribution. Then the elimination time will affect awakening. So what you have to remember with the ketamine is they'll start becoming responsive, but they're still not going to be quite awake. They're still going to be kind of lethargic. So you generally see that they become responsive about 30 minutes after that. And then full awakening is going to be dependent on how saturated they are. So if you've gotten somebody that's gotten large amounts of ketamine over a long period of time, they may take longer to have full awakeness. So it's somewhat dose dependent. All right, I will see you guys on Thursday. Please make sure you get your cases done. And we'll discuss those and then finish up the farm stuff.